Hi everyone, welcome to our first seminar of the year, fourth in total now. For those of you that are here the first time, my name is Dimitri Kesta. I'm a research associate in the Department of Radiology, and I co-organized this with Luis Machado, who's a postdoc in the Cancer Research Institute. And yeah, we want to organize this sort of to get people together working in the AI medical imaging space, share ideas, and hopefully also help anyone who's new to the space get started. Yeah, hopefully next time we'll also have food and drinks here, so please come join in person if you can. Get some coffee, tea, and also some pastries. And yeah, and also if you know anyone who might be interested in giving talks, so we're still looking for speakers for February, March. If you know anyone who might be interested in giving a talk here, please let us know. Or if you also would like to hear this talk from anyone specific, just let us know and we can reach out to them. Okay.
Yeah. So it's our great pleasure to introduce Dr. Ian. Ian obtained his master's degree in physics before going to study medicine. And he's currently a PhD student and clinical research at CCH at the Department of Radiology at Cambridge University. And he's working on these open source AI tool that combines chest imaging with clinical and laboratory data to support diagnosis and treatment planning for COVID-19 in the UK. So yeah, welcome.
Thank you very much. Yeah. Can I share it? Yeah, because I don't think they online can see it. They should be able to.
And the image of the screen reversed.
I'm looking, there's a comment in the box.
Oh yeah.
Somebody's question about. Yeah.
Oh, if they an easier way to do it, if they just pin me on their setting, otherwise I can share my screen, but it'll work better if they double click on the picture of me, if that makes sense. Okay. So in the participants, they'll see this and they just need to make this the and I think there's a way for the host to do it, but we'll check.
She said she pinned you.
Spotlight for everyone. There we go.
I've pinned you, but oh, that's much better. Thank you.
Yeah.
The right way around now.
Perfect. Thank you. Sorry about that. Okay. Oh, nice to see so many friendly faces. My name is Ian. I'm a PhD student in the radiology department, and as part of kind of the COVID response, there was lots of research money floating around, and I managed to get my PhD on that. So I am a second year, like mid-second year trainee in radiology. So graduated from med school, did foundation 1 and 2, did a bit of medical training, and then moved to radiology. So today I'm kind of going to talk about the pitfalls in machine learning in AI and COVID, kind of more generally, and then focus in a bit on what my project is and ask if anyone's got any ideas, basically. So it'd be good to have any input, and feel free to ask questions throughout, just nothing too hard. Right. So as I was saying, at the beginning of COVID, there was a lot of money floating around for research into COVID. And one of those projects was called Dragon, which I'll come on to in a moment, which is a European collaboration. But at Cambridge, our response was that the Department of Radiology, through Professor Agasala and Department of Applied Physics and Mathematics, Corolla, they kind of came together, formed a collaboration, including astronomy and data science and AstraZeneca, to look at how AI could benefit the pandemic response. So we ended up having Zoom meetings at 4:30 every day, 5 o'clock, I can't remember what it was, all the way through the pandemic, which was in a way quite nice because you had some social interaction at the time of very little. So that was quite a strange thing, really. And then Dragon is a big kind of collaboration of small and medium-sized enterprises and academia, which again is looking at preparing for future pandemics in terms of having an infrastructure set up that AI tools can easily be trained. So one of the projects is getting federated learning hubs in each centre. So should there be a pandemic in the future, you can anonymise your data, upload it, and then even if there's any pockets of data dotted around the centres, you can use all of it without worrying about patient privacy. So going into the pandemic, we did a systematic review at the start of, well, kind of, I think it was published about middle of 2021 of all of the AI papers to do with chest X-rays and chest CT applied for COVID-19. And you've all probably, well, you've all definitely seen a lot of the hype about, you know, chest X-rays AI on chest X-rays can diagnose COVID with an accuracy of 99%. I mean, it's pretty much impossible, isn't it? Let's be honest. It's too good. If it sounds too good to be true, it usually is. But there's been so many articles which have been saying we can do this, we can do that, lots of hype, and then not a lot has been delivered. I think in maybe Leeds, I think they deployed a model locally for diagnosing COVID-19 or triaging, but I wouldn't necessarily trust it. So this was one of my favourite ones. So it claimed to have an accuracy, I think it was 98% diagnosing COVID. So there's some images in the bottom right of the patients that were used to train for COVID and the patients that were used to train for non-COVID. They might be a bit small, but I don't know. Can anyone spot what the difference is if you've not seen this slide before? So basically, the normal ones are all of infants. So they're all children. And the problem with children's chest X-rays is that they look very different to adult chest X-rays. So they have a massive thymus in the top of their chest, their heart's bigger, their ribs are at a different angle, and so on. So all your training algorithm to do is choose between adult and child. But that got published. So the group went through a lot of papers and spent a lot of time. Unfortunately, I arrived after the bulk of the work was done, which was fabulous. But Cahill over there worked very, very hard, long hours to go through all the papers they found. And when they whistled it down, they found no papers that demonstrated models which you would trust in a clinical environment. So an example, one of the big problems was data sets. So a really nice example is that of, I think it's kind of been contested whether it's a Frankenstein data set or not, but I've always been told it's called a Frankenstein data set, where you have a open source data set that people try and make the biggest data set they can. They scrape all the images. They don't necessarily give their sources very clearly. Then someone else includes that in their data set, so it's bigger and more people use it. Then someone else includes that, and you end up with the same data set used 3 times in one thing. So there's been a lot of problems. So what did we do? We developed a number of models. I know Mike Roberts is talking, I think, in a couple of months, so I won't talk about everything that's been going on. only just stuff that's more relevant to my work. But at the start of the pandemic, we trained a chest X-ray diagnosis model. And we used a pre-trained a model using a data set called CheckSperts, which has got about 220,000 chest X-rays in it. And it's got labels from NLP of the radiology reports of 14 or 15 different pathologies. So we pre-trained a model with that and then used the COVID data to fine-tune it in different ways. So using higher resolution images, lower resolution images, fine-tuning on only the final layer, fine-tuning on different numbers of layers, the whole thing, so on. And also used segmented and cropped images to see what difference that made. And what we found is we got quite a good result. So our areas in the curve were kind of between about 82% and 90-ish, 0.9. And we found that it outperformed radiologists on the labels we had for some of the images of radiologists predicting whether people had COVID or not without having any other information but the chest X-ray. However, we then examined our saliency maps or class activation maps and found that a lot of the time the models seemed to be relying on kind of spurious confounding factors or shortcuts. So one of the big things was text, as you can see, and then other things were pacemakers and ECG leads, chest tubes, etc. So if I was having my disease diagnosed, I'd like it to be looking at the disease, not the stuff in it. It's fine on kind of population level, great results, but when it comes to you, it's not so good. So there's been quite a few papers now, not lots, but a number looking at different kind of biases in chest X-ray AI. And because COVID's been such a massive data set, a lot of them are focused on COVID. So looking at racial bias, gender bias, age bias, socio-demographic bias, and so on. And for example, I think gender, there are differences in the image that maybe it can use. So breast tissue, for example, and age, the bones might look different. They might have osteoarthritis in their shoulders and so on, or the quality of the image might be worse. But in some cases like ethnicity, I'm less sure it's about the image looking different for someone of a different ethnicity and more about the other biases that are associated with socioeconomic status or ethnicity. So this was an example from one paper by De Grave et al., which just demonstrated that when the model was, their diagnosis model was diagnosing COVID, it tended to look at the annotations, so the side labeling left or right. It looked at space around the patient or kind of patient positioning, and see if one, the position of the lungs in the image as well. So I suppose the really basic thing to think is, why is this happening? So I kind of, in my head, had a bit of a kangaroo court of, well, you know, if we're, as the humans, are learning about COVID chest X-rays, we're told it's COVID because there's ground glass opacity in the bases of the lungs. When we keep training models in an unsupervised fashion, they're just given the X-ray, right? So, of course, they're going to use whatever means of telling the difference they can. But then on the other side, is it that, AI is lazy and so on? I don't think so. I think it's more the pre-processing and what we're doing that is a bit, we're taking too many shortcuts and not spending the time that maybe we need to in understanding our data. So how could we solve it? I'm not really sure what the best solution is. So there's been various different ways. So Facebook developed something that they termed feature disentanglement, which is kind of penalizing the model for looking at things you don't want it to. So almost training it to learn the bits that you don't like in the image, and then penalizing it when it uses those features. Whether transfer learning is another way, or stratifying your data, so identifying all of the possible confounders in the images and then stratifying on everything, which might be difficult, but I don't know. So if anyone's got any good ideas, that'd be great. So when we came to think about it, we thought, well, I kind of arrived and was told one of my first jobs was to quality control the chest x-rays. So what does that really mean? There's not a clear definition of what you're looking for. Are you looking for images that are just terrible, that you can't see the lungs, or are you looking for an image that's got the whole lungs, or so on? So we tried to label as many things as we could because we suspected there might be such issues. And that took time, lots of time. So we thought if we could do that in an automated fashion, and then even non-experts who've never worked with chest x-rays in a clinical setting can get those labels, understand their data a bit better, look at how their classes might have different biases or factors within them. So that was where we came up to this idea of an auto quality control pipeline. So before I go on to that, I wanted to give you a chance to kind of diagnose COVID-19 on some chest x-rays. But I've not given you the lungs, so I think unfortunately our buried room is right over. Let me just move that down. So just from looking at that, but not the clearest images. But has anyone got an idea of which might be the COVID patient and which might be the well patient?
One on the right.
It's the.
It's the COVID patient.
Oh, I was hoping you'd say the one on the left. So, sorry, the software. So this guy has got a lot of text on the left and on the right. So it says AP erect mobile. So it's mobile chest X-ray, and it's taken in an AP fashion, which is why the patient's kind of rotated. The lungs are off in a weird place. And also they've got a endotracheal tube, so they're being mechanically ventilated. They've got central lines in, they've got a thermometer in, and they've got a chest drain in. So they've got all of these things. This chap on the right has got no external apparatus, but what he does have as well is the chest X-ray. The gold standard is to take a chest X-ray from the back, because then the heart's at the front. So with the diverging rays, the heart's as small as possible. So you see as much lung as you can. Now, those machines are fixed. So anything that's specific to that machine will be embedded in a PA. And one particular manufacturer puts a really kind of tells you which side it is, but it's tiny and in the bottom corner, and you can't actually see what it is unless you zoom in. But the problem is that is basically labeling every image just with that, saying this is PA chest X-ray. So we'll move on to number 2. So that's the final images. So this one's the COVID one because it's got all of this kind of muck in each lung. So that's not the technical term, but forgive me. So example 2, can anyone tell me which one they think is the COVID one? So I realise I'm running a bit slow, short on time.
Right.
Correct, yeah. So the one on the left is a lateral chest X-ray, which is why there's only one lung on it. So the one on the right's got all of this paraphernalia as well. It's got supine on it, which means that it's going to be taken from the front. Supine means lying down. So a well patient, you wouldn't image lying down unless they're having a CT. And laterals, we don't do a lot in the UK anymore. So this guy had actually had the lateral because he had a pacemaker. So it was looking at where his leads were for his pacemaker. So nothing to do with COVID. And then the final one, which one? So you've got an AP on the right and a PA on the left. Any ideas? Which one is the COVID patient? So wrong. It's the other way around. So this was to show that even though those biases might be good in a way on a population level and give you great results, when it comes to using it in practice, it's not so hot. So the AP has got lovely clear lungs. The guy with PA has got horrendous lungs. So coming on to our project, as I say, I went through and labelled all the images for as many things as we possibly could with a little GUI we made for the iPad. And then we've developed a pipeline of statistical and machine learning tools to label the images for us. So one of the first things we do, I'll just run you through them, is to standardize the grayscale. So there are DICOM headers to tell you which ones are inverted grayscale and which aren't. But in at least 2 of our data sets, there were a few. I think in one of them, there was 500 out of 15,000 that were inverted, even though they should have been uninverted. So we've got a model that will detect that and then flip the pixels if it's wrong. We have also applied the windowing. So I don't know how many of you know about CT, but there's something called Hounsfield units, so that every water is always 0. But with chest X-ray, there's nothing like that. That's what there is inbuilt things to make sure that every chest X-ray looks the same on the screen, or as close as it can do. So that's the only way of really making sure that the images are as close to similar as you can get. And then we score the images in terms of quality, looking at ranges of pixel values and so on in the center of the image and elsewhere. We make a mask of the annotations using some thresholding and filters, and then in-paint those to try and blur out, or at least kind of put in relatively normal pixel values so you don't have this massive contrast with the text. Crop the images, and also use an aspect ratio to try and pull out those where you've only got like half the lung. And finally, we kind of rotate the images. We remove laterals using ML to pick those out. And we label the projection, so if it's taken from the front or the back. So we use OCR to read the mask from the annotation removal. And if there's no annotation with that on, we use a machine learning tool. And then you can compare that to the DICOM headers, which are invariably either wrong or say 2 different views or whatever. So it's helpful. Okay, and then I won't run through, but most of the models we've got are very accurate. So inversion is a very simple thing for a machine learning model to tell whether the chest X-ray is inverted or not. And the lateral view is quite easy as well because there's only one lung and so on. So I realise I'm running a little short time, so maybe this can be the discussion afterwards. But we've got this pipeline. How do you show that there's a benefit? Because in a way, if you do this, you may actually make models worse because you're removing the things they're using to cheat. So in a way, you cannot train a COVID model with it and without it and go, oh, look, that one's better, because it won't work. So do you do that and then go through all the grad cams and see if the things you can see where it's using biases aren't being used less? The way I thought of doing it was in those papers that have predicted gender, machine, like hospitals and so on. Do you train models that detect the machine, for example, but use the kind of auto QC pipeline to harmonize the images, then use the labels for stratification and show that the performance of guessing the machine is reduced by using that? I'm not sure. And then whether we try and use it with, for example, using labels for feature disentanglement to teach the model that these are the things we don't want it to look at. And one experiment we did, which was very quick, which was to try and predict whether an image was taken from the front or the back, so PA or AP, and we just removed the label. So on here, it's got this PA label and the side marker, and then we inpainted it on the other. And you can see that the one on the left was classified wrongly as AP. If you remove the text, it's correctly classified as PA, both with quite high confidence. So I was thinking of doing a summary slide, and then I can't remember why, but I think I was looking for an image on Google. And I came across the wonderful website of safetymattersweekly.com, which talks about the dangers of shortcuts. And you might not be able to read this, but it says, for example, don't take the easy way out. Shortcuts affect more than just you, so they don't just affect your project, they potentially affect patients further down the line. It says, evaluate whether it's a self-imposed time pressure, which is why you're cutting corners, and having all of the necessary items for work tasks can help avoid the urge to take shortcuts. So I suppose that kind of translated for us would be making sure you've got all the right people on your project, that the radiologist is spending enough time thinking about potential biases. You're taking enough time to evaluate your model to make sure it's doing what you want it to do. And trying to develop ways to make sure that models don't take these serious shortcuts. So I think I'm a couple of minutes over. I want to say thank you very much for listening and for coming. And there's some acknowledgements bottom of people who particularly helped in this project. So collaboration, but Eduardo in astronomy has helped a lot with developing the models. Anna did a lot of the in-painting stuff, and then Mike is the lead for the project, and he's speaking in a couple of months. So thank you very much. If anyone's got any questions.